Thanks to everyone for listening in. I'm really excited to have Dr. Hayes with me to kind of explore this topic a little bit. Just some kind of housekeeping information in terms of where we're going with this. We will have some questions, some time for questions at the end. So feel free to send those along to the moderator, and we'll hit up some of those at the end. Do know that the focus of this is intentionally narrow because this particular topic has been one of great confusion over the last decades. It's kind of one of these mysterious things, this thing with transdermal hormones. If I've got and a lot of it has to do with how the testing ends up. But if you end up with a saliva test, serum test, and a urine test, they tend to correlate generally well, right? But then if I give a hormone deficient woman an injection of estrogen, which is pretty rare, like all three of those lab values are going to go up in response to that hormonal supplementation, right? But then when I move to transdermal hormones and I end up um, putting on a transdermal hormone, you get this really, really different paradoxical response. And the result of that has been, I've seen people use as little estradiol as 0.05 milligrams, which is a very small dose. And we've seen people here using doses over 25 milligrams. So that's a difference of 500-fold, right? So it's crazy the spread of doses that we see, but it stems from the confusion with the labs. And so we want to try to unpack this for everybody today. And then Dr. Hayes is definitely going to bring in some of the clinical side to this as well, as we just try to figure out together, like what should our best practices be for this particular subject. So let's start with what we know. uh, Patches are different than creams and gels. So when we talk about transdermal hormones, and I'm going to show you some data that just sort of highlights this, but patches act different than when you go and get either a pharmaceutical product like Divigel, which is a gel, or you go to your compounding pharmacy and you get compounded estradiol or Biest or something like that. Why? The creams and the gels, the saliva values go a lot higher, right? They're higher compared to patches, and they're higher compared to serum or urine. Another thing we know, which is why people are doing this, is it's risky to have too much estrogen, and it's also risky to have too little estrogen, right? We don't want to have patients with all kinds of osteoporosis. And so we've got, on either end of the spectrum, we've got some risk. And so we want to make sure that we're doing well by our patients, right? So, well, what do we want to know that can be a little bit confusing? Well, we'd love to know which doses of patches or creams and gels are effective clinically to get rid of hot flashes, to help build bone and maintain bone, for brain health, and so on. Then we'd love to know, how should we monitor these things? So with a particular scenario, do we want to use saliva, serum, or urine? And then what target values make sense, given what we know? Also, we're going to look at not just estrogen, but then how do we balance that with progesterone, given whatever we're doing with estrogen? What do we need to know about balancing that with progesterone? And then we also want to minimize risk when it comes to breast cancer or other risks associated with having either too little or too much estrogen. So I'm the owner of Precision Analytical. I've spent the last 15 years just digging through lab testing and trying to figure out um, what the best way is to monitor hormones. This testing matrix that we have and that I've been spending years kind of putting together is my and our best attempt to say, look, you have all of these different options, right? You've got oral progesterone, you've got transdermal estrogen, you've got transdermal progesterone, and then you have urine-based tests, and you have blood-based tests, and you have saliva-based tests, and they all have scenarios within which they work fairly well, and they all have scenarios within which they really don't give you the type of feedback that you're looking for when you're trying to get the right dose for your patient. So if you'd like that, we'll probably at the end of this send out a link to that. So if you'd like to have that as a resource, you can. And I'm really, really excited today to have Dr. Hayes with me. She has a very long list of impressive things that she's been up to over the years as an MD. She's been teaching for IFM since 2000. She's been affiliated with Baylor College of Medicine, University of Vermont Medical School, University of New England, Dartmouth Medical School, and currently affiliated with Tufts Medical School. And she's someone who I've been always really impressed with in terms of her just both clinical and pragmatic, but also intellectual approach to just trying to figure out with an open mind, like what is the best way that we're going to go about this. And so we're going to give her some time to speak to that as soon as we lay a little bit of foundational information. So thank you for being with us, Dr. Hayes, and
Oh,
welcome
that's
aboard.
very kind. Thank you. That's very kind of you, Mark.
So I want to start with a little bit about my journey. Okay, so these are the old assumptions that I kind of wrestled through in terms of the way I've thought, which has really changed over time in terms of what makes sense with these transdermal hormones. So this is the first one, and Dr. Hayes, and why I'm like so complimentary of her, is she's the one of the ones who really helped me understand this well. Some of these issues that I was kind of thinking poorly on is you have to get back to premenopausal levels. Like we want to get women into the middle of the premenopausal range. That is functional medicine. That I don't think is a philosophy that we should be necessarily promoting. Why? Because driving estradiol and progesterone up into the premenopausal levels, into the middle of those ranges, may in some situations require unnecessarily high doses of hormones. And as we approach this, the confusion is with the creams and the gels, right? And we can learn a lot from patches before we head into the sort of confusing area of this, because patches are pretty intuitive. So what we want to know is how much estrogen we're going to give somebody, right? E2 is estradiol. That's your primary estrogen. Ovaries make it, then ovaries stop making it. And here we go with estrogen replacement therapy. So if we look at a clinical outcome, this is bone mineral density. So this is the change in bone mineral density over a 12-month period. You can see the placebo here, and then you can see here's the lowest dose of patch, right? So you can see that for a the lowest dose of patch, you get a really significant difference to people who aren't taking any estrogen at all, right? And then you can see the lines above that up here are the higher doses of patches, okay? But the lower dose of a 0.025 gets you a really significant difference. You know, you stop the bone loss from the placebo group, and then you start gaining bone. So that's significant, right? Now, if we want to talk about hot flashes or vasomotor symptoms, you can see that the same dose, 0.025, is statistically better than placebo for getting rid of hot flashes at weeks 4 and 12, which are the two time points that they typically look at these things, right? So then the question becomes, okay, we know these work at this dose, and it's even more effective at the higher doses, but then obviously we're balancing that with risk of things like breast cancer and excess estrogen. But what is happening to the labs? So you can see here, the point on the left is the postmenopausal range there in purple, then up above you have the premenopausal range. And in this particular study for patches, the people not on therapy are in the postmenopausal range, and at 0.025, this lower dose, they're barely outside the postmenopausal range. So we're not anywhere near the middle of the premenopausal range, and we're seeing a very significant impact on the bone, hot flashes, and so on, right? So you might say, look, I have some history with serum that doesn't, I really don't like serum for monitoring therapy. That's the thing that's nice with patches, is you actually get agreement across the spectrum. So as we look at our Dutch results, this is based on a couple thousand women's results, and here's a woman not on therapy, or a lot of women not on therapy. Those on this low dose of patch are in a very similar place compared to the serum, right? They're just outside the postmenopausal range, and then they continue to scale up with the increased dose. And if you want to look at saliva testing, so there's your 0.025. If you want to look at saliva testing, you're going to see the same thing, in that the 0.025 dose on average puts a woman just below the premenopausal range for the saliva testing. And one of the reasons that we don't use saliva testing for estradiol, that's actually really highlighted well here, is if I have women in the upper part of this postmenopausal range, that's noteworthy, right? But if they're up in the early part of this premenopausal range, that's also noteworthy, right? And everywhere in between, you'd call sort of a modest deficiency for estrogen. The thing that's really challenging with saliva testing is there's just not a lot of hormone there. So for pretty much every lab that's testing it that way, there's a lot of overlap there. So if you have a perimenopausal woman and she's up in here, right, she's still making some estrogen. Whereas if she's down in here, her ovaries are failing and she's not making much estrogen anymore. Those two get commingled when you move to a saliva test. So that's why we don't use saliva testing for a baseline test, is it just doesn't differentiate the haves from the have-nots very well. But what we can see is for serum, for urine, for saliva, the doses that work just are getting people out of the postmenopausal range, and then they're more effective at getting rid of those symptoms as you scale up higher and then you approach and get into the premenopausal range. So that leads me then to the clinical side of it. For Dr. Hayes, what doses do you use if we're approaching this with patches? What lab values are you shooting for? And I'll put these up on the screen so you can reference them. And I'd also love to just hear like what your philosophical approach has been historically to try to figure out where you want your patients and your women to sit as it relates to estradiol.
Well, okay, first of all, I think it's important to note that when you're doing transdermal hormone therapy, it's not really how much hormone you put on the skin, it's how much hormone is getting to the target organs. And that probably the biggest piece of that is, do you have a patient who is a rapid absorber through the skin or a patient who is a slow or non-absorber through the skin? Because you can have some patients on massive doses, but you measure their hormone levels in blood or urine and there's nothing there, and they're still having symptoms. And you can have patients who go on a very low dose and immediately get breast tenderness or uterine bleeding, and you realize you've got too much hormone around and you have to cut down their dose. So it's important to remember that what we're aiming for is relief of symptoms, um, prevention of osteoporosis or cardiovascular disease or dementia, and avoidance of estrogen-related disease such as breast cancer or uterine cancer. So if I'm going to use a patch, I like to use patches that I can cut because then I can titrate the dose. So what I often do with a patch is I'll take the 0.025 patch, have them cut it into quarters, and start by putting 1/4 of a patch on their skin. And I like to put patches over thin skin rather than thick skin, and have them wear that for a week and see what happens to their symptoms. If nothing happens, they're still having hot flashes, they can't sleep, then they can go to 2/4 of a patch. And if nothing happens after, well, I might not make them wait 7 whole days if they're not getting an effect at that point. Go up slowly until they reach a point where their hot flashes are not waking them up at night and they don't have breast tenderness. So I titrate their hormone level to symptoms. At that point, I will repeat my lab value. I actually will have them hold at the level they think is their correct dose and hold at that level for a month and then repeat their hormone levels. And what's interesting is that I find that almost always, not always, but I would say 80 to 90% of the time, women will zero in on a blood level of 20 to 30 nanograms per milliliter. And that's going to, I'm sorry, picogram, 20,
Yeah.
wow, did I say milligram? Okay, 20, yeah, 20 to 30 picograms per milliliter. And Mark, you're going to have to tell us how that compares to the Dutch test. But I stopped using salivary hormone testing because I found that um, there were too many variables, and I was too concerned about the accuracy of measuring such tiny amounts of estrogen. So we know in urine we're measuring nanogram amounts of estrogen, in blood we're measuring picogram amounts of estrogen, and then in saliva we're measuring tenths of picograms of estrogen, and I was just concerned about the accuracy of that. So I also had trouble with measuring progesterone and testosterone in saliva, so I just quit using saliva. So I've been kind of an advocate of using serum, but I have gotten interested in the Dutch test. I think I'll stop there unless you.
Okay, no, I think that's helpful. And I've kind of highlighted on here the range you're shooting for, and I just want to also let people know, like I know some people have a philosophical approach to HRT, which pushes them to slightly higher doses and slightly higher target, values, and that can be okay. And we're going to discuss at the end, like what should our approach be, for example, with balancing with progesterone, at the lower doses and at higher doses. And I think that's important to discuss because again, it's a balance of risk between getting rid of some of the estrogen symptoms, but then also minimizing the risk associated with too much estrogen. And this is where we get into what's led to a lot of confusion. Is that the patch data to me seems pretty clear, and it's intuitive because you're getting similar responses in all of the lab tests. What about creams and gels? What works for those? So here's what we're going to do. We're going to start with the doses people use and the clinical responses. There's enough FDA data on the responses to bioidentical pharmaceutical transdermal gels that we can work with that. And then once we see that, then we'll allow that to inform our thinking before we move on to what's going on with the labs. And I think that will make some sense. So for the patches, we started at 0.025. Why? It's shown to help, and Bethany's even starting a little bit lower with her patients. It's shown to help bone loss and hot flashes, right? So what cream or gel dose gives the same clinical response? That's a really good question, and we could look at that. 0.25 is a great place to start. Why? It also is enough to help relieve symptoms. So let's look at it. So for bone loss, you'll remember that the patches showed increase of bone mineral density at all the doses of patch that we were looking at. And with the gel, the lowest dose does not separate in this study from the placebo group until you use either a higher dose or you stick with that lower dose and you wait until you get to 12 months. And at 12 months, it starts to separate, which would tell me that that lower dose is just enough hormone. Remember, at 6 months, the patches worked at all the doses they looked at. For the gel, the lower dose is just beginning to work. And if you keep at it for 12 months, it does work. It's effective. Okay. What about hot flashes? For the patch, we saw better than placebo at 4 weeks and 12 weeks with 0.025. So what about creams and gels? For Divigel, 0.5 and 1 milligram worked at 4 weeks and 12 weeks. So we got the same impact for those doses as the patch. But when we go down to 0.25 milligrams, and this was really impactful for me in terms of what this means about this dose of 0.25 milligrams, it was not statistically different at week 4, but it was at week 5, which again gives this message that it's just enough hormone to start getting the impact that we get from the doses of the patches at even those lower doses of 0.025. Okay, so 0.5 milligram gel doesn't separate from placebo until 5 weeks. Higher doses work at 4. So what is that going to leave me with? 0.25 of cream and gel and 0.025 of the patch give a pretty similar clinical response. They both help with bone density, but the lower dose just barely works. It's better at a higher dose for the gel. Same with hot flashes, right? 0.25 gel took longer to work, and at 0.5, it was equivalent to what we saw from the patch. Okay, so then what happens as we dose these things with the gels? What happens to the labs? Okay, so if we look at serum, we get a really, really similar response. So first thing to just clear up, these are the people not on therapy. And you might ask yourselves, well, shouldn't those be the same? Well, these are different studies. So maybe it's a slightly different group of women. I think it's more likely that the assay that they're using is probably a little bit different. And if you correct for that difference, it's pretty much superimposable data. So 0.025 of a patch gives you basically the same serum number as 0.25 of the gel, which also gave you a very similar clinical response. So patches and gels fairly equivalent, right? The Dutch results, we've got a couple thousand people here, and we're looking at basically the same data, whether we look at 0.25 of a transdermal gel or when we look at 0.025 of a patch, and we can even throw creams in there. So here's a compounding pharmacy making a cream for women. And again, this is a pretty big data set, and you're getting about the same data as you scale up the dose of the patches or the creams and gels. Patches, gels, creams, they're all doing about the same thing. So when we look at transdermal estradiol, bone losses, bone loss, hot flashes, we're getting equivalence between these doses about, right? When we look at serum, we get about equivalence. When we look at urine, we get equivalence. So we add all those three together and say, and I know I'm making this point really slowly, but it's for a reason, we're getting equivalence between these approximately. What about saliva testing? With saliva testing, 0.25 milligrams of a cream or gel is much, much stronger than the patch. And in fact, it's actually much, much stronger than even the highest dose of a patch, right? So let me show you the data. So here is patch data, the average value from thousands of women who've said, I'm taking none, I'm taking 0.025, 0.5, 0 or 0.05 and 0.1 of the patch. That's what you get, right? And then when you look at the cream, what you can see is this 0.5 data point where it's just starting to give an equivalent response as the lowest dose of the patch. You're getting these really, really big values, right? Now, that's at 12 hours. So 12 hours after the dose of 0.5, you're way north of premenopausal ranges. 8 hours, you're probably about greater than 20 picograms per milliliter. So there's a lot of estrogen there. And then at 24 hours, when you're ready for your next dose, you're still way above the normal range. So you're cycling between these ranges there, between about 10 times higher than the highest dose patch and about 3 times higher than in terms of saliva values of what you get with the highest dose of a patch. So those values, I think, don't jive with the clinical data, and the clinical data seems to uh, coalesce around these doses making sense as being equivalent to each other, and you're getting the same message approximately from urine or serum, but you're getting this exaggerated response in saliva. So back to my old false assumptions. You got to get back to premenopausal levels. You really don't to get some clinical impact. Serum and urine levels don't go up with creams and gels. They do go up with creams and gels, and it's a fairly linear dose-dependent response. The other thing that we see is that I used to be a proponent of is that saliva is speaking for all of the other tissue, that it's a tissue surrogate. We can see that the saliva gland is not speaking for the bone. It's not speaking for the hot flash response or what's going on in the brain. And if you switch gears, which we won't do, but if you looked at testosterone, the muscle mass that accompanies topical testosterone only comes when the serum values go up significantly. And in all of those men, they're getting these really, really big exaggerated responses in saliva. So for the muscle, for the brain, for the bone, the saliva gland in this situation with transdermal hormones is not really speaking very well for the other tissue. The other false assumption that I think was really important for me to wrap my head around is that estrogen and progesterone, they actually don't behave the same. Progesterone is really lipophilic, it's really fat soluble, and it behaves differently than estrogen. And so this conclusion that many people will say serum and urine values don't go up with creams and gels, that is fairly true for progesterone. And I'll show you the data here in a minute after we end this discussion. But it's actually not true for estrogen. They do go up in a linear dose dependent manner for estrogen, and it seems to correlate what's going on with the symptoms, right? So if we push serum and urine levels to the middle of the premenopausal range, what do you end up with? You end up with this overdose of hormone, right? It's more hormone than you need. On the other side, if you use saliva testing and you push to the middle of the premenopausal range, or even a little higher, you may run the risk of underdosing. So then how do we dose transdermal estradiol, meaning creams and gels, right? Start low, go slow. You're going to want to give it some time, and that's an important fact. Look at this is actually from a kind of random patch version. The reason I chose it is this data. At 2 weeks, the lowest dose of patch is barely separated from placebo. So you're getting all this impact just from the placebo, and the patch is barely separated from that. But when you wait till week 12, it's barely separated from the higher dose. That's pretty nice to get that much clinical impact if you're willing to wait to separate pretty significantly from the placebo. And it's not that different than the higher dose. So you want to give it some time. Don't forget about the impact of the placebo. And then, of course, we're going to want to balance with progesterone as needed, which is a separate question that we'll have Dr. Hayes share about. So, how do we test it? Right? How are we going to monitor it? Because that's a really big confusing question with especially creams and gels. I think the data is compelling to me to monitor with serum or urine testing. The Dutch test works really well. If you're using serum, you're going to want an ultra sensitive method so that you're getting a good number or an LCMS number. Target values that are above the postmenopausal range just slightly or into the bottom third of the premenopausal range. That's a pretty good place to find yourself to balance the low and the high sort of targeting of how much estrogen. So my new assumptions for estradiol are that you want to be out of the postmenopausal range, meaning above it, that serum and urine values actually parallel the clinical effects fairly well, and that saliva testing, while it's useful for certain scenarios, it's not helpful with dosage monitoring. The old assumptions lead to this very often. Really, really low doses, so maybe 0.05, maybe 0.15, and what do you get? You get normal to high saliva results plus some placebo effect, so you're going to get partially reduced hot flashes even if you just give a placebo. And what is that going to lead to? Really, there's some risk there of osteoporosis or having not enough estrogen. So now I'm going to hand it back over to Dr. Hayes. That's sort of been my story over the last 5 or 10 years of trying to figure out what should we be doing as an industry with transdermal creams and gels. So I'll ask you the same question that I asked you about the patches, which is how do you approach those in terms of doses and in terms of lab values? And then we'll get into progesterone balancing.
Well, there are a whole lot of things to respond to here. First of all, I think we need to remember what where we got our quote normal levels for menopause. And a lot of that data was collected when many women went through surgical menopause. So they had damage to the uterovarian blood supply, or they lost their ovaries, and I think had sudden drops in hormone levels. And the second issue that I'm noticing has affected the hormone levels that we measure are xenoestrogen in the environment, which we don't measure, but which may have an effect on how we metabolize and excrete estrogens. And the third thing is that there's a rather dramatic amount of autoimmune damage to the ovary, and those ovaries are not only not producing as much estrogen, they're not producing as much testosterone. And so I latched onto slightly above the menopausal norms because I thought the norms were actually low. That doesn't mean I'm aiming to get out of some pathological menopausal state. It means I'm trying to find the right dose for an individual woman based on averages of normally menopausal women. So I'm aiming for the 20 to 30 picogram range in blood because I think it mimics normal menopause. And I think women who go through normal menopause describe it sort of like this. Oh, yeah, I stopped having periods. It was great. That's menopause. Now, the women who are not having that response to their menopausal experience are often women who are high stress, have many other medical problems, they have gastrointestinal problems. And if we approach in a holistic way, cleaning up all of those other problems, then it doesn't take as much estrogen to get rid of their symptoms and to improve their osteoporosis situation. So I kind of never bought into the I have to return to the premenopausal level. So let me just run through why I think that. First of all, I have an innate trust of Mother Nature. She's been doing this about several billion years longer than I have, and I just think she's smarter about it than I am. I do think that once human interventions like hysterectomies and environmental toxins came into play, it was harder to find what Mother Nature's plan was. Um, so I think Mother Nature makes good decisions for women's longevity by returning their hormone levels to lower levels when they no longer need to be having babies because they don't have the bone and cardiovascular structures to make that reasonable. Um, the next argument I hear is, but 30-year-old women are healthier than 60-year-old women, so we should return their hormone levels to the same level that 30-year-old women have. And my answer to that is, well, okay, they are healthier, but what about 11-year-old women? They basically have menopausal levels, and I would say your average 11-year-old is as healthy or maybe healthier than a 30-year-old. So it's not that menopausal levels are unhealthy. It's that other things that are happening with age make us unhealthy. My third point is that estrogen is hormetic. Too much is bad, too little is bad, and we have to find our way through that pathway with bad on either side to a point that is the ideal, to be as healthy as possible. I spent a lot of time reviewing the literature to figure out what normal hormone levels were, and I found two things. Number one, I found that early in menopause, the levels ranged right around 20 picograms per milliliter. And the second thing I found is that levels fall off after menopause. They continue to fall until about the age of 65. So I reevaluate what normal is at around 65. The next thing is we can't lump all postmenopausal women together. And most of these studies, wham, they just lump them all together. You know, surgical, non-surgical, it doesn't matter. They're all menopause. And they don't lump early and late menopause. You know, they lump them all together. So you're dealing with women who have very low estrogen levels and having atrophic vaginitis and osteoporosis, and you're lumping them with women who are at high risk for breast cancer. And I think we need to be separating those out. So if you start low and go up slowly in your hormone replacement, you can get relief of symptoms at the lower end of that white area on Mark's slide, or at the upper end of the menopausal area. And
Right.
and then if you have a patient who is desperate to get rid of her hot flashes this week, I've seen those people, like I have a big event, I have to get rid of these hot flashes now, then I think you can give hormone therapy. It's not hormone replacement therapy, it's hormone therapy, and give her a higher dose, give her some relief, and then back off of the estrogen very slowly. Don't have to just stop it like we did all those women who read the Women's Health Initiative and stopped their hormones and then went nuts and went back on their hormones. We can slowly drop those hormone levels back down into normal for menopausal range, and you're answering the needs of your patient without taking significant risks. So I'll stop now and let Mark continue his brilliant discussion of laboratory.
Yeah, no, I like it. I like we're getting a little philosophical. That's good. But that's really practical as well. So I appreciate that. So, but I'm going to throw it back to you though. With this question is, how then and when do you balance with progesterone? And I would like, if you can, to address both groups of the. I just gave you enough estrogen to get you out of the postmenopausal range. I've relieved
Right.
your symptoms. That's where you are. And the group that says, you know what, I'm going to push a little heavier and I'm going to get you up into the early part of the premenopausal range. So if you could discuss that, that'd be
Okay.
helpful.
Well, we know from bad experience that too much estrogen alone without enough progesterone to balance it produces endometrial cancer. So I think it's important to remember, if you're going to go into the premenopausal hormone range, you're going to have to give premenopausal levels of progesterone. And if you do that, you have to cycle progesterone. If you give premenopausal levels of estrogen and continuous progesterone, you're mimicking pregnancy or the birth control pill, and you're going to increase the risk of diabetes. Now, if you're giving if you're giving postmenopausal levels of hormone, then you're basically doing hormone replacement therapy and returning people to normal menopause. In normal menopause, we don't give progesterone. In normal menopause, there's enough progesterone being produced by the adrenals to handle that low amount of estrogen, and we don't have to cycle and we don't have to go to very high levels of progesterone. The trouble is that most of our patients who come into our office who are complaining of hormone symptoms really don't have the healthiest adrenals, and so they have a lot of cortisol steal. They're taking their progesterone and turning it into cortisol, and so you have to kind of think about, do they really have enough progesterone if their adrenals are shot? And the other problem that you get into is the failure of understanding of the conventional world about returning people to normal for age and the risk of that. So if you're giving estrogen, it's assumed that you're giving high doses of estrogen and you'd better be giving progesterone. Consequently, if you have somebody who you are doing hormone replacement, returning them to normal for age and not giving progesterone, there is some data in the literature that supports doing that. But you're going to run a risk if that patient has an endometrial hyperplasia or cancer, which can still happen even if you're giving adequate amounts of progesterone. If you have that patient and you're not giving progesterone, you're going to have some legal problems. And so I would say giving small amounts of progesterone when you're returning people to normal for age is not a bad idea.
Yeah, and we had talked before about in that situation where you don't feel like you need a lot of progesterone, using a little bit of transdermal is a good practical way to go. And as you push, and you can correct me if I'm wrong, but as you push up near and into the premenopausal range, which is a different scenario, then you really need to legitimately balance with progesterone that's proven to balance premenopausal-ish levels of estrogen. And in that case, oral progesterone might be a better option in that situation. Is that, would you agree with that?
Well, what I would say is the way you can test are you in the premenopausal range is if you give oral progesterone and stop it, do they withdraw? Do they have a menstrual period? Do they have
Right.
bleeding? If
Right.
they do, then you're in the premenopausal range for estrogen. Um, if they don't bleed, I'd give it a couple of shots at that because we know that early in menopause, the hormone levels are rocketing around, sometimes high, sometimes low. So you might test them when their levels are really low and they're having a lot of trouble with hot flashes. And you're giving some
Right.
estrogen and you give them progesterone, they don't bleed, and then next month, oh, the hot flashes went away. You're such a great doctor. Wow, you gave me all this great drug. I'm never going to get rid of this drug ever again in my life. But what really happened was their own estrogen levels came up.
Right.
In that point, you give them progesterone and they may bleed. So I would test it a couple of times before I am absolutely certain that I'm not giving enough hormone to need progesterone. And Helene Leonetti did some studies on transdermal progesterone and found that 20 milligrams of transdermal progesterone, I can't remember if she gave it once a day or twice a day, but she showed that while it does not produce secretory endometrium, does not bring on a period, it also does not allow the endometrium to proliferate. So it doesn't produce a growing endometrium that can get you into trouble with endometrial cancers and bleeding episodes. So,
Right.
yeah.
Well, and one of the challenges that we have with transdermal progesterone, which has led to so much confusion, is that the labs are even more confusing than with the estrogen. And this is a topic that I have been sort of hunting on for really honestly since my first job in like 2001, where I found, wow, transdermal progesterone doesn't increase urine metabolites very much. And so I went from that and I looked at serum values, and people started talking about red blood cells. So we looked at whole blood, we looked at arterial blood, we looked at blood spots, we looked at saliva. It said, I can't make sense of it. We even had like custom metabolites of progesterone made that nobody's testing. We looked at like 11 different pathways that progesterone goes down.
Yeah,
in
well, you
my
have to remember progesterone is an upstream hormone. It's way at the top of the cascade of steroid hormones. So it has lots of pathways it can go down. I just think, you put progesterone in and it's gone. It's just, it goes so many different places. You're going to have trouble measuring, and you're going to have trouble keeping blood levels up. The
and
reason that it works so well when Mother Nature does it is she does it in pretty high levels right out of the ovary, goes right into the uterine circulation, and you get the effect you want.
Right, and with transdermal progesterone, the conclusion that I've come to is that there really isn't a lab test that speaks well for it to the point where you can change doses for transdermal progesterone. And I'm not going to go into that too much, but these would be some of the points that have led me to think that is that the saliva results are really variable from one day to the next when you don't change therapy when you're on transdermal, but they're 100 times normal, right? They remain elevated. And this is interesting. They remain elevated for months, sometimes 6, 7 months after you stop therapy. So the progesterone is getting into the fat. The saliva, I would describe it, has special access to those fat soluble hormones when you give it transdermally. But it doesn't reflect what's going on in the breast and the uterus and elsewhere. And urine and serum results, they don't increase significantly with the dose as they do with estradiol. So let me show you my data. So this is based on several thousand women, right? So when I move a postmenopausal woman not on therapy to 20 milligrams of progesterone, I move her from the middle or bottom of the postmenopausal range up a little bit, right? And then I say, okay, well, that didn't work. I'll tell you what I'm going to do. I'm going to increase the dose tenfold. And look what happens. It barely moves, right? When you look at these numbers in saliva, the 20 milligrams has already got you way, way above the premenopausal range. And as you increase the dose to 200, which I wouldn't recommend, then it's skyrocketing even further, right? And I think the tissue, what's going on at the tissue level, is it's really still a pretty perplexing situation. And so for me, I do not think that there is a lab test that will really help us with transdermal progesterone to the degree for me that I am more comfortable with oral progesterone when you really need to balance estrogen. And obviously, you can use vaginal and some other routes of administration as well. But it really is a confusing kind of situation. Here are some references that discuss some of these things that we've been discussing. And then I wanted to circle around to one of the things that Dr. Hayes mentioned is, if you're trying to combat hot flashes with estrogen, and you have a stressed out person who's having the sympathetic nervous system going crazy and having that type of a response, that's going to play a big role as well. So the reason we use the Dutch test, and I'll get into that in a minute, is for some of the other things that we're measuring. But as it relates to the hormone of interest of estrogen, there is a benefit of doing a Dutch test that's a dried urine test for comprehensive hormones, because we're collecting 4 urine samples throughout the day, and a patch is going to be stable throughout the day. So serum's a little bit better with a patch than it is with a cream, because with a cream or a gel, you're going to get an up and down pattern throughout the day, and you have to time that a little bit. With the urine, we get an all-day average, and that's nice. The other thing that we look at is the metabolites, right? So we're looking at, this is a Dutch report, how it would lay out. We've got estradiol here. Here's your premenopausal range. And let me just zoom in on this a little bit. So this woman is high for estradiol. So if she's on therapy, one thing you might say is, well, she's taking too much, and that might be true. But the other thing you'll notice is that as you go down the 2-hydroxy pathway, it's low, which means this pathway is blocked, if you will. So that's a woman who might concurrently need some DIM or some I3C to push estrogen down this 2-hydroxy pathway, particularly so if her 4-hydroxy estrogens are high. We know those have carcinogenic potential, and that's one of the really nice benefits of a urine-based test like the Dutch test, is we can see the estrogenic 16-hydroxy, the carcinogenic 4-hydroxy, and then what's thought to be a safer estrogen, which is the 2-hydroxy estrogens. So that's a lot of nice additional information. And then where are we going from here? 2-hydroxy is going to get methylated, and we can measure that. I didn't show that here, but we can look at that as well. If you've got a methylation problem, that's a piece of the puzzle that we really want to add. So the other thing, as I mentioned, is we're looking at cortisol throughout the day, the metabolites. There's a lot of information there that's beneficial. Androgens, the organic acids are really interesting in that we're looking at glutathione deficiency markers, B6 markers, B12 markers, as well as the neurotransmitters. So we're getting a window into that epinephrine world as well. You're getting all that information in one test. And in addition, I think it's really a really nice way to look at oral progesterone. Oral progesterone, serum and saliva work pretty well for monitoring progesterone, but not if it's oral. So if it's oral, you're going to have some issues because you're going to take it at bedtime. It's going to go up and then back down. And by the time you head for your lab test, most of it is gone. So we're trying to look at this big picture in the Dutch test to really give you a lot of information on not just the hormones, but how they're metabolized and some of these other factors, cortisol, melatonin, neurotransmitters. So that leads me to our last set of questions for Dr. Hayes, which is what other factors impact hot flashes and other estrogen related symptoms? And you've mentioned some of those, but could you speak to those a little bit and how that impacts your treatment?
Yeah, what I've noticed in my practice is if I get women into a reasonable range of estradiol and they're still having hot flashes, they're invariably high adrenaline people. They tend to be thin, they tend to be anxious, they are kind of wired, they're over exercising sometimes. Um, and they are, if I can get them to initiate programs to lower their adrenaline, like meditation, heart math, breathing techniques, getting enough sleep, their hot flash numbers and intensity go down dramatically. So I tell women that they can actually use their hot flashes as a monitor of what their hormone levels are doing, and of how stressed they are. So if they're having a lot of hot flashes, their stress level is up, and they need to address that. With osteoporosis, we know that's an inflammatory disease. So if you have a patient who has enough estrogen, they should be making bone and they're losing bone, they've got inflammation going on, and we need to address inflammation in the gut, in the overactive immune system, and see if we can't get that turned around. And then always checking vitamin D levels and adding vitamin K to that picture will often turn that bone loss around. And I recommend Laura Pizzorno's book, Your Bones, because she had severe osteoporosis and turned it around dramatically. Um, and she just studied, she's a bright, bright woman, and she just studied every possible thing that could affect your bones, and she's got it all in that book. So it's a really great thing to hand to people if they're struggling with osteoporosis. Um, the the other thing, Mark, that I was going to say when you were talking about the metabolites, you taught me something very important, and that was that the 4-methoxyestrogen is very, very, very low in amounts, and so we really need to uh, measure the 2-methoxyestrogen and extrapolate. Rather than trying to pin down how much 4-methoxyestrogen you're making. And the experience that I always had clinically was, okay, they've got low 2-methoxyestrogen. I know they're not methylating, and I would put them on methylation factors. I could never get that 4-methoxyestrogen up. So I think, so my approach was methylate them, get them methylating. Don't worry about the lab value. If you can get the 2-methoxyestrogen up, you're doing great. And work on getting less hormone going down that 4-hydroxy pathway.
Right, right. Yeah, I think that the reality is with a lot of methods. I mean, I've seen 4 different labs add 4-methoxy E1, start reporting it, and then pull it off of their report because you realize you're just measuring background noise, and it's better to not oversell it and get your methylation information from the 2-hydroxy, 2-methoxy, and extrapolate than it is to really strain at that 4-methoxy. So. Okay, so we've got enough time, but maybe not too much to go into this real deep. But we had talked earlier when we were chatting about the pre and postmenopausal women's response being a little bit different to specifically progesterone, and I thought what you had to say about that was really good. I wanted to give you a chance to discuss that.
What did I say?
You're talking about that
Well,
one particular study as it relates to that.
Oh, well, I think uh, something that sort of got overlooked when we began to look for is bioidentical progesterone good for the breast or not? And the probably the best study that came out looking at that had the most people in it was the E3N study, which was a study in France, and they looked at bioidentical progesterone. Um, they were cycling people with it, and their abstract drew the conclusion that bioidentical progesterone does not increase the risk of breast cancer, whereas artificial progestins did. But if you actually looked at the study, that's not exactly what it showed. What it showed was early in menopause or early in the course of the therapy, which I assume was given soon after menopause because that's when women have the most symptoms. Early in the course of menopause, the progesterone actually decreased their risk of breast cancer. At around 6 years, it leveled out to about a 1 to 1. In other words, it didn't increase it, didn't decrease it. But after that, it actually increased the risk of breast cancer. So I think there is something different going on with progesterone in the postmenopausal woman than in the premenopausal woman. The only difference between those three groups in the E3N study was how close they were to menopause, meaning how high their estrogen levels were on average. So I think I've continued to delve into the literature about progesterone. And what we find is that progesterone in the breast actually, each time you start a cycle of progesterone, you induce a cycle of a cell cycle turnover in the breast. And so I worry that people who are giving high doses of estrogen and therefore have to give high doses of progesterone and cycle it may be driving breast cells through multiple cycles of division when they don't need to be. Um,
Oh,
so
that's really
that's,
interesting. I think it's an area where you can see too that there's more research to be done to really
oh yeah,
be
we are so
precise.
far behind understanding progesterone. It's pathetic.
Yeah, and to be more precise about what we're doing, and I think, and that's where we do have different sort of philosophical approaches to some of these things. But there are some, I think, definitive things that we can pin down, and so I think that's some good feedback.
My
Okay,
my
so
take my take home is also read more than the abstract.
right. Yeah, no, yeah, for sure. Okay, I know we're gonna have some people that are gonna ask about estriol. So, what do you think about, when you do you throw estriol in for everyone? Do you just give it vaginally? Do you, what is your, what are your thoughts on adding estriol into your estradiol therapy?
Okay, I absolutely love estriol vaginally. It is highly effective. It does not deal with all of the symptoms, particularly in women who have dysbiosis and vulvar uh, uh, problems. But if their problem is estrogen, it works really well. There's a lot of data in the literature. The conventional world says, oh, there's no data on that. That's just wrong. There's just a ton of data from Europe. They've been using estriol in the vagina for a long time. So estriol cream in the vagina, magic, use it. You can use it in breast cancer patients. You can use it in little old ladies. You can use it. I never worry. I just give them a prescription forever. Um, the problem with estriol in transdermal estrogen or oral estrogen is if it does anything, I think it may block the estrogen receptor, which means if you're giving estrogen to get an estrogen effect and you block the receptor with a weaker estrogen, you're going to have to give more estradiol to get the same effect. And that doesn't make much sense to me. If I'm giving estrogen, I want to get the best effect. I want to give the form of estrogen that gets into the circulation, gets across the blood-brain barrier, and I can give the smallest amount of. So I can give tiny little amounts of estrogen, to get picogram levels of estrogen. But if I give estriol, I have to give higher doses. And so the the oral estriol in autoimmune disease, I think, is really interesting. There's a growing body of information on that. As far as if you're wedded to the concept of biased and you're giving it transdermally, I don't really have a problem with that. I don't think you're going to hurt anything, but you may have to give higher doses, and then you have to metabolize it. So
Gotcha.
I give estradiol, progesterone, and testosterone, and I don't add estriol in unless I'm giving it vaginally.
Okay. That's great. I have a few questions from the audience that I'm going to interject here before we get to my last question. Is just a little bit redundant, so I want to make sure. Amy asks, is there any research on vaginal progesterone in terms of lab levels and dose needed for the clinical effect to protect the uterus? And I think this is an interesting situation where we have to think well about it and say, okay, if I give progesterone not on the labia, but truly vaginally, then you get this uterine first pass effect, right? So the uterus gets more hormone than its fair share of progesterone when you give it vaginally, and that is not going to be reflected in any lab test. What you're going to see from a serum or from our Dutch test is you're going to see the level of systemic progesterone uptake. You might care about that number. If that's the case, then I think the lab values speak well for that. I do not think it represents well what's going on in the uterus because it has special access to that progesterone and there's no body fluid that speaks for that. Did you have anything to add to that, or do you agree or disagree with that?
I think that's true. The problem with vaginal progesterone is it's messy, and women hate messy. And Crinone, which is the FDA approved version, is very messy and clumps, and it's like cement. It cements to the wall of your vagina and then it comes out in clumps. It's really awful.
Yeah. Okay.
However, you do get really high levels of progesterone in the uterus, and we know that because we can prevent miscarriage sometimes
Right.
in women who have luteal phase defects. Um, so if you're going to use it as a substitute for oral or transdermal progesterone in somebody who you're giving premenopausal levels of hormone, I think you're going to have to um, do an endometrial biopsy and look at or at least do a vaginal ultrasound and look at the how much risk you're taking in terms of proliferation of the endometrium.
Gotcha. Okay. I've got a really practical question for you. When we cut the patch, as you suggested, which if you use the higher dose patch might be a good way to save a little money. But do we
Yeah, it does.
still do we still want to have the control? Do we still get the controlled release feature of the drug when you do that?
It depends on the patch you use. So if you are using like a Climera patch, which is it's like a piece of sticky paper, you can actually cut it in half and get a half a dose or a quarter of a dose. If you're using a patch that has a one of those um, uh, little spaces that has estrogen in it and it elutes the estrogen, then you can't do that because you cut it in half and you break open the
Gotcha.
the hormone containing chamber.
Okay. And I did want to add one thing as well, and that is when you're talking about vaginal estriol, I'm not going to go into why, but I don't think there's a reason to follow up with labs. The labs don't really speak very well. You're looking for a localized impact. The
Yeah.
local tissue are going to be way higher than what's in serum or anywhere else, and there's really no reason to test that. I just wanted to add that. And then there's a question related to that for you, which is, do you just use compounded estriol when you're looking for vaginal estriol? Thanks for
Yeah,
the question, Joy.
because we don't have the estriol ovules that they have in Europe. If you can get them, that's great.
Right.
But no, I use compounded.
Right. Okay. And then last question I've got for now from Tim, and thanks for the question, Tim. But is there data suggesting higher levels of bioidentical estradiol predisposing to breast cancer? And I'll let you speak to that. My thought on that would just be that there is data that says the more a woman's exposed to estradiol, whether her levels are naturally higher, throughout her life, or she starts her menses earlier, or whatever, that you do have somewhat higher risk for breast cancer. That's bioidentical estrogen. That's your estrogen. So if we add to that number, then we do have to be concerned about that. But I think you could probably speak better to what the studies might say about that. So bioidentical estradiol predisposing us to breast cancer if you've got too much of it. Can you speak to that?
Okay,
Assuming
well,
you're taking progesterone too.
Okay, so the the point I think the questioner is making is we know that Premarin is primarily metabolized down the 4-hydroxyestrogen pathway, and there was a lot of concern that that might be why we saw more breast cancers in people on Primpro. Then they discovered that really the artificial progestin was a large piece of the problem.
Right.
Um, so all of it was fascinating. The pharmaceutical industry figured this out long before they told us about it, because you notice way before we started switching to estrogen to bioidentical hormones, the whole bioidentical hormone thing came up. The drug companies were putting bioidentical estrogen into all their preparations, so they switched us a long time ago. Um, I think that the issue of does bioidentical estrogen cause or not cause cancer is, yeah, Mark, you're right. It's the lifetime exposure of estrogen. I don't think if you put somebody on estrogen and 6 months later they have breast cancer, I don't think you caused it. I don't think that estrogen caused that breast cancer. I think it was much more likely that that mother was exposed, that woman was exposed to estrogen in utero, that she had higher levels of xenoestrogens throughout her lifetime, that she produced higher levels of estrogen from early menarche and heavy periods, and higher levels of estrogen in perimenopause. And it's really perimenopause that I worry about adding to the estrogen load. Um, so I don't think we're going to know the answer to that question about whether giving estradiol makes a big difference or just a little bit of difference. But I think we have to assume from all the data we have on estrogen that your overall exposure to estrogen makes a difference in your breast cancer risk. And if some of that estrogen is at the hands of doctors, the doctors had better be very careful about it.
Gotcha. Okay, thank you. That's great. And then my last question, which just kind of relates to all this, is what do you think about estrogen metabolites? You've spoken to them a little bit. Do you always test them? Do you only test them for people who you think have a high risk of breast cancer? Like, and that for us, it's sort of a moot point because it comes along for the ride when we're looking at estradiol. But what are your thoughts on the estrogen metabolite utility?
Well, I always test them because I am often giving supplements in an attempt to get better estrogen metabolism. And
Right.
what I discovered was that there are people who have high levels of 2-hydroxyestrogen, and you don't want to give those people DIM or indole 3 carbinol.
That's a good point.
So I always test to see if I've got, because I had that patient, she had breast cancer. And then I went to the literature and it says if you have the the rapid form of CYP1B1, it increases your risk of breast cancer. I thought, wait a minute, how can that be? Because you'd have more
You,
2-hydroxyestrogen.
you
That's
mean
the
one
good
A one?
estrogen.
That's one
Uh,
A one, right?
yeah, 1A1. I'm sorry,
Yeah.
1A1.
Okay. Yeah.
You would have more 2-hydroxyestrogen, and I'm thinking, well, that can't be right because that's the good estrogen. So I had to go and read all the literature, and sure enough, 2-hydroxyestrogen can also make DNA damaging quinones. They just don't stick to the DNA as bad as the 4-hydroxy does. So if you have really high levels of 2, you can get into trouble with that. And so no sooner did I learn about that than the patient walked into my office with a really high level of 2-hydroxyestrogen and breast cancer. Um, the second thing that I use the metabolites for is to try to get a handle on the 4-hydroxyestrogen, because of Eleanor Rogan's work on the DNA damaging quinones. It is, I think, quite likely that 4-hydroxyestrogens play a significant, not an 100%, but a significant role in the production of breast cancer. And then those of you who might have gone to the functional medicine conference this spring learned that the 4-hydroxyestrogen DNA damaging quinones, that's the place that the double-stranded DNA antibodies attach to in autoimmune disease. And I was fascinated by that. So now I'm really interested in women who make autoantibodies and have 4-hydroxyestrogen DNA damaging quinones.
Forgive my first grade drawing here, but just for those of you that aren't familiar with them, 4-hydroxyestrogens make a quinone, which damages DNA. The 4-hydroxy attaches very strongly, rips a piece off. The 2-hydroxy attaches more weakly. The other issue with the two is if you make a lot of the 2-hydroxy, we think of that as a safer estrogen. But if you make 2-hydroxylated metabolites out of polyaromatic hydrocarbons, those are much more carcinogenic. So if you have someone who's a big 2-hydroxylator or you want to give someone DIM, it's also a good idea to, I mean, most of these people aren't smoking, but stay away from cigarette smoke and polyaromatic hydrocarbons because those things become more toxic as you go down the 2-hydroxy pathway, which may play a role in the increased breast cancer risk for those people with that CYP1A1 that upregulates that 2-hydroxylation. But I think that's an excellent point that we don't just indiscriminately give DIM to people, right? You want to look at their metabolites, see who they are as it relates to processing estrogen. How's the 4-hydroxy? How's the 2-hydroxy? How's the methylation? The other thing that we do that's nice is that quinone, one of the detox pathway is through glutathione. And so in these nutritional organic acids, we've also got a glutathione deficiency marker, and part of the methylation requires B12 and B6, and we've got B12 and B6 markers. So that's what we've been up to, is trying to piece all of this together. If you get a lot of DNA damage, you can increase the 8-hydroxy. So we added the oxidative stress marker. So as you're trying to piece all of this together, estrogens and metabolites, what's going on with the cortisol, the melatonin, right? If melatonin's lower, then you have an increased risk of breast cancer. So there are all these different pieces that we can put together that relate to the overall health of the patient. And that's what we're trying to do with the Dutch test. So I really appreciate your time, Dr. Hayes. Appreciate you joining us. If you have questions, feel free to reach out to us at info@dutchtest.com. If you're a provider and you've not tried the Dutch test, it's a super easy test for your patient because it's just a few dried urine samples throughout the day, but you're going to get this sort of treasure chest of information. It's really cost effective, and we've got a half price offer for any new providers that you can
It is
try up
the
to 5.
easiest. It is really easy to do. It is really easy to do. Even I could do it.
Yeah, thank you. We built the test for information because we're looking at the cortisol pattern, we're looking at all these metabolites and hormones, but the natural byproduct of the way that we developed it is really simple for your patients to do. And if you want some more information on that, and even if you have any other questions on serum testing or other routes of administration for HRT and what we're supposed to be doing for best practices, this is a conversation that we would love to continue, and we appreciate all of you listening. Your feedback is welcome as well. We do know these are controversial topics in terms of dosing, in terms of philosophical approaches to progesterone and estrogen and testing. And I think one of the things I've appreciated about Dr. Hayes is just that open-minded of like, let's look at the information and let the information inform us and not dig our heels in too much on any particular approach because it's a dynamic situation. It's not static. We don't have all the answers. The jury's not back entirely. And if you have information or questions as it relates to those topics, we would love to hear from you and continue dialoguing, whether you're using our testing or not. This is a conversation that we really enjoy being a part of as we all collectively within functional and integrative medicine try to change the way people are doing things for the better. So thank you very much, everyone, for joining us.